everyone for coming. I'm going to speak today on adhesive capsulitis or frozen shoulder. So we'll just briefly an outline, we'll go through a definition of what frozen shoulder is. We'll talk about the pathology, natural history, and then we'll just talk about the non-operative and operative treatment options. So the history, first time that the pathology was described was by Duplay in 1872. He wrote a paper in which he called this pathological process the periarthritis scapulohumerale. In 1934, the term frozen shoulder was first coined by Codman, who put out a paper describing this condition of where people have a limited range of motion of their shoulder that was self-limiting with no treatment after 2 years. And then 10 years later, Nevessier out of the US wrote a paper in the JBJS talking about adhesive capsulitis. He was the first one to really talk about the actual pathological process. And he used a case series of operations that he had done, as well as a series of postmortems, and he presented this as a case report in which he was the first to describe that there's this element of the capsule being involved in formation of adhesions, and that was the cause of this restricted range of motion. And more recently, in the 1990s, Zuckerman had a well-defined definition of the idiopathic adhesive capsulitis to try to define it from those situations where people get stiff shoulders or painful stiff shoulders after things such as trauma, previous surgery, things like that. So adhesive capsulitis, the best definition that we can have is a process in which a patient presents with increasing pain in their shoulder and a progressive limitation of range of motion of the shoulder in both active and passively. There's no defined cause, actual etiology of why this happens, and it has a characteristic natural history of starting off with pain, and then they call it freezing, where your shoulder is frozen, and then towards the end there's a third phase in which your shoulder starts to thaw and you get a gradual return of range of motion. Depending on the different reports over the years, they've talked about it being self-limiting within 18 months, or some people talk about it being up to 4 years in duration. So this is a well-known graph, I'm sure you've seen it before, and it describes this pain being the preceding element, and then there's an overlap in where the pain and then the stiffness starts to come in and a gradual loss of range of motion. It's in all planes, and they always talk about external rotation. Some people define it as losing up to 50% of your external rotation. And then at the end, pain gradually subsides and your shoulder is still very stiff, and then you get a gradual return of your range of motion. And we call it, there's the 3 phases. They call this first phase in which you get pain and then your shoulder starts to stiffen up as the freezing phase. The area where it is stiff is the frozen phase, and then the thawing phase. And as you can see from this graph, having pain in your shoulder without any real loss of motion is very non-specific, and it's very hard in the early stages to have an acute diagnosis of adhesive capsulitis. So the demographic of people who get this is predominantly females. All the studies and reports I had were going around 60% of the cases that they had were females. The average age is in the 40s, between 40 and 60 years old, and is less likely to happen in people with physical jobs. So people with sedentary jobs are more likely to have this, and it can be bilateral. Now, I've read reports, some people describe it as being more common on your non-dominant arm, but there are also reports out there which show a slight favoring for people's dominant arm, so it's not quite clear there. It has a high association with diabetes, and diabetes is also a bad prognostic indicator. Studies have shown that if you have diabetes and a frozen shoulder, that your overall outcome will be worse. The general population, they say, is about a 5% incident, right? Where diabetes, it can be up to 30%. Hypothyroidism, recent open heart surgery or ischemic heart disease, having some kind of innocuous shoulder injury, or sometimes shoulder surgery can bring this on. Having cervical disc disease is also a common thing. So the workup, clinical exam, no focal point of tenderness, and shows a broad, reduced range of motion in all degrees of freedom. X-rays are usually normal. You can have some element of osteopenia, disuse osteopenia, but generally they're reported as being normal. If you have other pathology going on, such as arthritis, that can be, indicate that it's not frozen shoulder, but there's another primary process, pathological process going on. Your bloods, ESR and CRP, can be done effectively to help exclude infection, which is always a risk, and a painful stiff shoulder or polymyalgia rheumatica can also have a similar presentation. MRI can show capsular thickening, and some studies describe having a 4 millimeter thickening of the rotator interval as being pathognomonic with frozen or adhesive capsulitis, but it's not necessary in the diagnostic phase, or it's not necessary to get a diagnosis of adhesive capsulitis. So the pathological process is on your left here. You can see this is a diagram of a normal shoulder joint, which shows a nice looping axillary fold in the joint capsule. And this is important for, because the shoulder is such a mobile joint, we need quite a loose capsule. And then the pathological process in adhesive capsulitis, in particular in this axillary recess, the capsule becomes very adhesive to itself, and sometimes as well to the humeral neck. And this is attributed to the loss of range of motion, because as the shoulder thickens up and gets very tight, it restricts your range of motion. Now, going away from the clinical phases, there's also been 4 histological phases described, and these are pictures of arthroscopies that on various patients that have shown this pathological process in the different histological phases. So stage 1, there's a fibrinous inflammation phase, an early synovitis. There's little adhesions formed, but you can see this is looking at the rotator interval on the bottom, and that's the biceps tendon. And then as they go into a stage 2, there's a synovial proliferation and early adhesions start to form. Some people have thought that this is not an inflammatory process, but certainly there's these histological studies that I read in the JOS show that there's certainly inflammatory cells in synovial biopsies and in the capsule biopsies. So it does have an inflammatory process. And then stage 3, as this goes on, it starts to mature, and it becomes more of a fibrosis type of reaction versus an inflammatory reaction. And then that can probably describe why the pain starts to fade away, and you're just left with a stiff shoulder. And then in the chronic phase, this is trying to show the rotator interval in the biceps tendon, saying that scar tissue is well formed, and it becomes very difficult on arthroscopy to distinguish normal anatomy. So treatment options, the mainstay is definitely non-operative treatment. Physical therapy, both self-led or directed by therapists. Steroid injections have a role. Hydrodilatation is used in some parts of the world with good effect. And then there are some reports of laser therapy or suprascapular nerve blocks being effective. And then operative management, manipulation under anesthetic has been described for at least the last 60 years. And you can also use a capsular release, and that can be done arthroscopically or open. So physical therapy has for a long time been the mainstay of therapy. It involves mainly range of motion exercises and getting people to regularly do exercises to work on increasing their range of motion. There are studies that show up to 90% of patients treated non-operatively with physical therapy alone have shown to have satisfactory results. And certainly JOS describes that you should in their review last year that you should have at least 3 to 6 months of physical therapy before you try any other forms of intervention. So this is a randomized study or it's not a randomized study, it's a prospective study coming out of the US in 2000. So 75 consecutive patients with idiopathic adhesive capsulitis, all treated with a minimum of 6 months of physical therapy alone. And 64 of those patients, so 90%, had satisfactory outcome. And that was partially on their own interpretation of the results that they had, as well as some functional scores. 5 of these patients went on to have a manipulation under anesthetic. And all the patients, all 75 patients, did have a residual loss of range of motion in the affected shoulder compared to their unaffected shoulder. So I think this is a key point to take home, that when you have frozen shoulder, you are not likely to regain a full range of motion. And I found this interesting, that workers' compensation was shown to be statistically significant to have a failure of treatment. Steroid injections are interesting, and they're interesting to study because a lot of these patients who present to surgeons who are doing trials have already been seen by their GP, and certainly a lot of the papers find that people have had prior injection of steroids, and it can be hard to distinguish whether it was subacromial or intra-articular. There's a systematic review published in March of 2012 that unfortunately they were unable to do a systematic analysis of all the papers because the quality of the papers weren't good enough. But they talked that there was good evidence for short-term pain relief. In the 6 to 12-week period, people with intra-articular shoulder steroid injections did better with pain, and some of them did better, had increased range of motion. So in the medium term, beyond 12 weeks to about 6 months, they also showed better pain. But in the long term, all the studies that they've shown, there's no significant difference in the long term at final results that intra-articular steroid injections give any of these patients a better long-term outcome. And I thought it was interesting that it's, again, because it's such a hard disease to diagnose early, there's this inflammatory phase, and theoretically, injecting steroids should calm that down and improve pain and range of motion, maybe stop the process from happening. But it's so hard to diagnose early that we don't have any studies showing what stage or how long they've had adhesive capsulitis and when steroid injections are given. So that might be some room for future study. So hydrodilatation is described using some kind of fluoroscopy or imaging to inject the joint with normal saline or some kind of other fluid. Some people inject steroids as well. They talk about in shoulders, the normal shoulder joint capsule has about 25 to 30 mils of capacity for fluid. When in frozen shoulder, that can be reduced down to about 5 to 10 mils. So the theory is you inject fluid and you slowly increase the amount of fluid until the joint capsule ruptures. So the typical way of that being done is using X-ray, putting a needle into the joint to make sure that you're in the joint, and then injecting some radio-opaque dye, and then slowly pumping in normal saline until you get joint rupture. That can happen most of the time in the studies that I've read in the subscapular bursa, but it can also happen regularly at the bicep, the long-headed biceps insertion into the joint. So there was a Cochrane review in 2009 that showed there's 196 people included in these studies. Again, they weren't able to do a full analysis because the papers didn't provide it, but they claimed that there's silver evidence for short-term benefit with regards to pain and range of motion, and that's in comparison to range of motion exercises alone. Manipulation under anesthetic, obviously it's under anesthetic. It's important of complete muscle relaxation to allow all the force that you're putting in to be going straight into the joint. It can be done in the beach chair. It can also be done in the prone position. One technique that I read about was first working on external rotation and then forward flexing as much as you can and trying to externally rotate again at maximal flexion and then bringing the arm back to 90 degrees of forward flexion and working on internal. There's a well-described audible pop, and some people think you need to hear at least 2 to 3 pops before it can be successful. And there is a risk of humeral fracture. That's the main risk with this treatment. Capsular release has been going on for many years. There is now a tendency to go towards arthroscopic. The goal is to divide the capsules, particularly anteriorly, starting from the supraspinatus tendon, so going to the muscle belly of supraspinatus, through the rotator interval, and then down through subscapularis to the inferior port of the joint capsule. Particular care must be taken inferiorly, as the axillary nerve is very close in the inferior glenoid tubercle. And then there's debate whether the posterior capsular release is required routinely. Some people do this as a day procedure and send them home and start physiotherapy on day 1. But some people like to admit these people for 2 or 3 days and give some supervised physiotherapy treatment starting in hospital. Open repair is reserved for failed arthroscopic now, or sometimes if you can't identify the anatomy very well on intra-articular arthroscopy, it may be safer to do an open release. Open capsular release is routinely done through the delta pectoral approach, division of the thickened capsule. If you cannot gain full range of motion on the table, if you're not happy with your range of motion, you can do a Z lengthening of subscapularis, which will also increase your ability to externally rotate. And then again, there's debate whether you should routinely do a posterior capsular release or not. So there's been a lot of studies involving manipulation under anesthetic and non-operative treatments, as well as MUA versus capsular release. Found one interesting study in 2001, 135 patients out of 1,700 who'd gone through this center over an 8-year period with frozen shoulder. 135 of them proceeded to have a manipulation. 54 of those patients had a manipulation, and they were happy on table with the range of motion, and no further treatment was required. These people were excluded from the study, so their long-term results were unknown. And 81 patients had arthroscopic release, and they excluded 31 patients. So out of those 50, they divided them into 3 groups. The post-operative people, so those were people who had a stiff shoulder after they'd had a biceps repair or a rotator cuff repair, or some kind of shoulder operation. There was people who had had a recent fracture that had been treated, and idiopathic adhesive capsulitis. And this study showed that arthroscopic release, all patients had an increase in their symptoms of pain and range of motion. They all improved. And idiopathic and post-fracture groups actually showed better results, and they had lower pain score at the 6-month follow-up. They had better function, better satisfaction, and their overall function was statistically greater compared to those patients who had adhesive capsulitis post-surgery. So there's 11 patients in the idiopathic group, all showed significant improvement, and there's only one failure of treatment, and that was from some biceps tendonitis. When that was fixed with a tenodesis, that patient also done well. So arthroscopic, the point of this slide is arthroscopic release does show good results, and people do get better with arthroscopic release. Certainly in all of the studies that I've read, there seems to be the non-operative treatment patients have slightly better results, but it's not statistically significant with regards to comparing that to manipulation under anesthetic and arthroscopic release. But I think it hasn't really been talked about. We're only doing the arthroscopic release and the manipulations for those people who fail physical therapy. So to me, that always makes sense, that they're never going to do as well as the people who are managed non-operatively and do well. So in summary, non-operative treatment is the mainstay of treatment of adhesive capsulitis. There's no long-term evidence for steroids, but certainly there is short-term evidence that it provides some pain relief. hydrodilatation has certainly multiple studies that show that it does work and is better than physiotherapy alone. Surgical management should be reserved for those patients who fail at least 6 months of non-operative treatment. And then last point is they're unlikely to gain full range of motion compared to their non-affected side, but they're still likely to have increased range of motion and increased function.